classification of the levels of recovery for traumatic brain injury is Rancho Los Amigos levels of cognitive function.
That's what I told you when she said you were doing good.
It describes the sequence of recovery based on behavioral patterns. It's in your book. It's table 12.2. It has 8 levels, and there are a couple different videos. One of them's kind of long, so I'm gonna do the shorter one. But this one at the top is good. It's a speech therapist doing it, so it's good to understand from a cognitive perspective. Whereas I believe this one is a PT professor. So.
When I was accepted to SU, that was one of the greatest days of my life.
Hi, I'm going to be showing you the Rancho levels of cognitive functioning scale, which consists of 8 total levels. I'm going to do the first 4 on Samantha. The first level is no response, and the patient requires total assistance. At level 1, the patient is completely asleep, and they have no response to any painful stimuli, verbalizing, and they don't respond to any noises as well. Sam, can you hear me? Sam, can you feel this? They're in a complete stage of coma. Rancho level 2, they have a generalized response and they are still in total assistance. They can open their eyes, but they are not able to focus on anything specific. Sam? Sam? She's able to open her eyes, but she's not able to focus on anything. She's kind of just staring into space. Rancho level 3, the patient is still in total assistance, and they are now able to listen to me and focus on specific people or objects. So Sam, can you hear me? Now she's able to focus on me, and she's also able to look around the room, focusing on specific objects to try to figure out where she's at. Rancho level 4 is confused and agitated. The patient is now maximal assistance, and at this level, the patient may become easily aggressive. Sam?
Don't touch me. Don't touch me.
Can I work with you?
No, don't touch me.
Okay, that's Rancho level 4. Now Jobin is going to introduce Rancho levels 5, 6, 7, and 8.
And so Rancho level 5 is when they're confused and inappropriate. They may still be at a maximum assistance. It's whenever they're going to have an unpurposeful response to outside stimuli, and they're still going to have trouble retaining your information. So Sam, how about we go do some therapy today?
Blue pen, Gamecocks, bananas.
All right. And Rancho level 6 is when they're confused and appropriate. Their memory and attention span are getting better, and they may be able to tolerate therapy for about 15 to 30 minutes, depending on how they react. So Sam, how's it going today?
Good.
How about we just do some therapy for a short amount of time in your room today? Would that be okay?
Yeah, that sounds good.
All right. And Rancho level 7 is automatic appropriate, and that's when they're still able to do ADLs, but they may need supervision in their room or wherever to perform therapy. So Sam, how's it going today?
Good.
How about we do some therapy today? Would you need any help before we get into the gym?
Yeah, I need to get dressed. Can you help me to the restroom?
Yeah, sure. I'll be right over here. And Rancho level 8 is when they're purposeful and inappropriate. That's when they're usually about standby assist to independence, where a patient is able to do ADLs all on their own. But yeah, you may need to be aware that she may be distracted in an open environment, so you may need to do a closed environment. So Sam, we're going to be doing therapy in about 15 minutes, so it is okay to get ready. I'll be back.
Yeah, I just need to brush my teeth and get dressed, and I'll meet you in the gym.
Sure, sounds good.
Okay. So.
Hi, Marley!
Hi, Dad.
I'm coming with you. Did you bring your own?
So, he went through those quickly, but your book has a whole chart of it. So one of your checkoffs is to create an intervention at each level. So, be an intervention at each level, so 1 through 8. So if you have a patient at level 1, what would you do for intervention? We walk in versus up to level 8.
What can you do with it?
Yeah,
What do you think you can do? If they're non-responsive, what do you think you need to do?
You said the best thing. Okay, so like level 4 on here, and am I supposed to assume the patient gonna do work again?
They may or may not let you. That's the thing with TBI.
The assignment say that y'all work with us.
What would you plan to do to work with that patient?
Cause that's not saying like that would just be my intervention, like, because like.
But what would that be though? If you went in, what would that look like?
What would education be, like, I can do- because like if they.
Or are they gonna be able to be educated at that point in time? Are they gonna remember?
But then you're not gonna wanna work, with
Maybe
them.
we need it functional.
So like I can
So
just.
that, so we free.
What you need to be trying to do is arouse them. So you provide stimuli for the patient. Right? Whether that be auditory, tactile stimuli, proprioceptive stimuli, through the range of motion. You're providing that sensory input that they need in order to facilitate moving to the next level. Because your job is to continue to help them in that process in order to get to the level of alertness that they need in order to do their ADLs and their activities that are functional for them, like ambulation. So that's what I mean by going back down smaller, like think smaller and not so big. Or you can provide tactile stimuli. I mean, it doesn't have to be just tapping on them. You can help the CNA bathe their legs, or you can do the passive range of motion. You can do the sternal rub. You can sit and talk to the patient. You're giving them some type of sensory input. And you'll hear some people that have been in comas and they remember people talking to them. They remember people coming up and having conversations to them. They weren't able to respond, but they remember being there and having that conversation. I think so. So a concussion is an injury that is likely a result of a blow to the head that may or may not produce loss of consciousness. So the mechanism of injury is damage to the reticular activating system. Do y'all remember the reticular system I showed y'all? That's when we impact the ability to coordinate sleep-wake cycles and wakefulness. and it can cause changes in vital signs. A concussion can be secondary to an acute trauma from like a motor vehicle accident or when athletes get head trauma. So the way that the American Academy of Neurology classifies concussion is a 3-grade system. So grade 1 is no loss of consciousness with some confusion. The confusion will resolve in 15 minutes after the event. The patient may have recollection of the event and can return to athletic activity after 1 week of rest. In a grade 2 concussion, that's when it lasts confusion lasts or symptoms last longer than 15 minutes. The symptoms can include poor concentration, retrograde amnesia, antegrade amnesia, we'll talk about in a minute, removal from athletic activity, and cannot resume until these symptoms are absent for 2 weeks at rest and with exertion. Grade 3 is any form of loss of consciousness. They have to have a full neuro exam at the ER. They are to be withheld from athletic activity for a month. This form of concussion is a diffuse axonal injury. This is the one that we talked about. It's severe enough, it can result in coma.
So like now with athletics, like anytime you coach, you have to go through like a whole lot of concussion plays. And you have to be certified, and then like when you say like you can return, they make it just like the doctor clear you, and you can get into your coach, and then your coach has to say on can you return.
Yeah, and I think the rule is typically if you have 3 reported ones, then you can no longer play the sport.
And then you'll actually like get in trouble as a coach for that.
Yeah. I'm not sure about this video.
A concussion is a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth.
Do you see that?
This sudden movement can literally cause the brain to bounce around or twist in the skull, stretching and damaging the brain cells and creating chemical changes in the brain. What you might not know is that these chemical changes make the brain more sensitive to any increased stress or injury until it fully recovers.
I just liked that picture. I felt like it kind of gave a good picture of what really happens. I can't remember it now. So your PT is going to evaluate the patient. They're going to assess their cranial nerve sensation, their coordination, their strength, range of motion, their muscle tone, so that decorticate and decerebrate rigidity. They'll do a skin assessment, a functional assessment, and a gait locomotion assessment. They'll ask for their prior level of function, what their home environment is. Sometimes, or a lot of times with these patients, that information may have to be given to you from the family because the patient is not able to self-report. So do y'all remember these? States of altered consciousness. This is table 21.2 in Lundy. I made the copies for some of y'all before we had our midterm. So we need to review these, okay? Okay, so the classification of memory impairments. So antegrade amnesia is the inability to create a new memory. This is the last to recover post-coma. Symptoms may include poor attention, distractibility, impaired perception of stimuli, so they just can't remember what happened. Post-traumatic amnesia is the amount of time that elapses between the injury and when the patient is patient cannot recall the injury or the events until this point in recovery. And then with retrograde amnesia is the inability to remember events prior to injury. It usually affects recently restored past memories, not memories from years ago. I got all of these from the Cleveland Clinic. They are not in your. But you could be tested on them on your board, so. Also, in your book, it says in the beginning that you have to be basically specialized in order to treat somebody with a TBI. That's not necessarily the case. If you came in and started working at regional, my boss is not going to discern whether or not you're a new grad and just not give you the guy with the TBI. I mean, you get what you get. So, and I've never seen them just not give you a patient because they have a TBI. You're definitely going to have to work with TBI patients out of school. So, I don't quite understand why your book states that. But these patients are not just needing a specialty. TBI patients are hard to work with. I mean, they really are. A lot of times they're inappropriate. Sometimes they can be aggressive or agitated. Some of them can be touchy-feely, inappropriate. They're not always the funnest patients to work with. Some people love them. So what are some interventions we can do with these types of patients? So, of course, we're going to be assessing their muscle strength, their range of motion, and this will directly impact their ability to do certain exercises or what position they may be able to be in order to complete those exercises. So be prepared for those saying that flaccidity or an abnormal tone or abnormal synergy patterns that you still see with upper motor neuron lesions. So those things can still impact someone with a TBI, okay? So if you have a hematoma up here pressing on your frontal lobe causing damage, what do you think is going to occur? The same symptoms that you have with stroke, we're still impairing that same area. So those symptoms still apply with a TBI.
Is that typical, or is that typically what you'll see more is like frontal lobe
I mean,
TBI?
I would say yes to that, but I have seen occipital lobes.
From falling?
Or car crash. I had one, actually I have one. It's MBA, occipital craniotomy. I would. So typically if they do a craniotomy, they take the bone out. We talk about this, but they take the bone out. Sometimes they'll put it in their stomach, so that it will preserve, or sometimes they put it in the freezer. It just depends. And then after the swelling in the brain goes down, they'll place it back. And then if it doesn't take, then sometimes they have to do a metal plate. But when the craniotomy is done and they don't have their skull in place where it needs to be, it leaves that area open to vulnerability. And when you have someone who has either flaccidity or abnormal tone and then abnormal synergy patterns with movement, you risk them falling, right, with mobility. So when they're up moving, they have to wear a helmet. Okay, and they'll come with a helmet, and they have to have it on when they're up and out of bed. That is a safety thing. I'm saying it really clearly right now. So if I have a helmet, and you have a patient on your final, that has a helmet, needs to be on their head when they're up moving. Wouldn't be in a helmet. From injuring it further. Or fall. They have the possibility of falling. They're a high fall risk.
How much less than
You should look that up. You wanna look it up for me? Alright,
maybe for us?
I don't know, see. Okay. So, some of the interventions you wanna do are seating considerations, pressure relief, therapeutic exercise, functional training like the mobility that we've been doing, and the bed mobility, the transfer training, your balance deficits that come along with that. We wanna do gait training and neuromuscular reeducation. So, I will say also, a lot of times they've been in ICU for a prolonged amount of time. That means that they are not in an upright posture for a long time. Their length of stay in acute care is much longer, so that can impact, what do you think? If they're laying, huh? Well, their tone, yes, so it can make them have some atrophy, right? But what else? Bed sores, that's good. What?
Pressure sores.
Pressure sores, yeah. But it can also impact blood pressure, right? So they may have positional, hypotension, okay? So in the beginning stages of treatment, a lot of times it's getting them used to tolerating upright position. So it's starting laying down, increasing the bed to maybe 35 degrees, then to 45 degrees, then to 55 degrees, just continually sitting them up, checking their blood pressure, seeing how well they tolerate that. There's this thing called a tilt table I can show you. If the patient is able to bear weight through their feet, then that's a good option, in order to facilitate getting them used to sitting upright as well. Or standing in gait. You can use the TED hose and the abdominal binder as well in these patients. But remember, a lot of times you need an order from a physician for TED hose, so you need to make sure you're getting that before you start putting it on them. Because there are contraindications to wearing TED hose. You don't wanna wear TED hose if you have kidney issues, congestive heart failure. You could be overloading your system with more fluid than it can process. So the doctor has to discern whether or not it's appropriate in some instances. And 9 times out of 10, they don't mind, so most of the time it's appropriate. But you're right, atrophy is a good thing to think about, and then bed sores. And that's why something that's really going to impact your ability to treat these patients is their cognition. It is very difficult to redirect these patients. My golden rule with treating a patient that has a true TBI is they direct care most of the time. They tell me what they wanna do and we do it. So we had a patient at Regional that was there for like 30 days. She had a true TBI. She was a post worker. She delivered mail for a living. And so every morning she thought it was time for her to go deliver mail. So they would walk her to the front desk. They would hand her a stack of envelopes and she would go to every room and give people mail. Because that was her job every day. So we did things that they want to do to facilitate recovery, okay? Because a lot of times it's gonna be very difficult to redirect these patients and get them to do what they need to do. So sitting down and doing kicks, they are likely not going to do what you ask them to do. If they're mobile, they're gonna wanna be up, moving. So what you might expect to see cognitively wise is that they may process things slower. So you may have to say what you want them to do, give them a minute to retain it and see if they can produce the outcome that you're asking for. If they can't, then you may have to start the process over again. Divided attention, so that means like if I'm sitting doing raises here, they can't watch TV and do exercises at the same time. They can't divide their attention that way. So if you're doing exercises in the room and there's a TV on, you turn it off, or at least mute it. I'd prefer you turn it off because even the visual is going to distract them. And if there's a family member in there that's being overbearing and not allowing you, it's continually interrupting treatment and causing a distraction for the patient, that might be a situation where you said, hey, while I'm in here, can it just be me and them? Because I really want them to concentrate while we're working. They're gonna have a hard time sustaining attention. So you might ask them to do 20 kicks on both legs, and they've done 5 on one, and they just are sitting and looking at everything else that's going on around them. So they're easily distracted. Motor and cognitive function do not take a linear path. So their motor function may improve completely, and then cognitively, they may still be highly impaired, which makes for what? A really high fall risk, right? Because they have no insight to their deficits, they're not self-monitoring appropriately, so their safety awareness is completely impaired. So your recommendation, if they were leaving your facility and they continually needed that assistance, is that they need 24-hour supervision. That would be the safest option for this patient at that point in time. And there are social constructs to that, like patients may not be able to afford that, like to have caregivers around the clock, or they may not have a family member that can stay with them around the clock. So there are barriers to that discharge, but that can be your recommendation. Doesn't mean that your recommendation changes because their symptoms don't change. The thing that's wrong with them doesn't change. I mean, and some of my TBIs have been completely mobile individuals that literally just cannot attend. I've had people come back and like give me hugs and say, I don't really remember what happened here at all for like 2 or 3 months of their life. They don't remember me, but I was their therapist. He came back and he was like, I know I gave y'all hell. He gave me a hug. He was like, I'm so sorry. It was okay, you know? They've told me I was a handful. Okay. I was on the brain injury team at work, and our leader, Miss Adrian, she came up with the 4 Ps. So I'm going to bestow the 4 Ps upon y'all. The 4 Ps are potty, personal items, positioning, and pain. If you can address all of those before you leave a patient. If their ability to communicate is impaired, then make sure you're addressing these appropriately. So potty means they may not be able to verbalize that they have to go to the bathroom, so just take them, okay, before you leave them. Personal items like their phone or their call light, make sure they're on the side that they can reach, okay, or even put it in their hand and re-educate them on how to use it. Positioning, make sure that they're in a safe position when you leave them. Their alarms are on and activated, right? So we know when they get out of the bed or they get up from their chair. Pain, they may not be able to verbalize that they're in pain. They may have some nonverbal communication of pain when you move them. So you need to make sure that that is being addressed. If it's by nursing, giving medication, whatever it may be, that you can do to ease their pain. So, with these patients, you want to make sure that you deliver an appropriate sensory experience for that intervention and for their level of function. So, if, let's just say, we have a moderately impaired TBI and they're agitated, and I've taken them into the gym, and there's 5 other patients in the gym with us, and they increase and escalate their behaviors. What should I do? Huh? Yes, take them somewhere private, right? Make sure their needs are met. Make sure that you are meeting whatever need they need met at that time. And then redirect back to what you're working on. So there are policies and procedures in place at most facilities that help manage behavioral escalations. So there's typically a code for a combative patient. You need to know what that is if you're working with a patient that has a TBI, so that if you get in that situation, you can call the code and you can get help, okay? You also need to make sure that the patient is safe, but also that you are safe. So you don't want to turn your back on these patients. If you're walking out of a room, you'll want to walk facing forward while you're watching, okay? And make sure you do a thorough chart review, because if you may have read maybe the pre-screen or the initial history and physical that the doctor does, but you need to read that PT note before you too, because that's going to tell you whether or not that patient was agitated. And so also know that your disposition and how you come to treatment impacts their disposition. So you can deflect what you are feeling in that moment onto them, so you don't come frustrated. And don't be frustrated with this patient, because they're gonna pick up on that and that can escalate their behaviors. better to be calm, direct, speak in very short, precise things, like, okay, let's stand up and walk across the room. And instead of, okay, Miss Smith, let's stand up and let's go for a walk, and I think we can do that. That might be too much for them, right? Might be overstimulating for them. So just be calm and direct, and that will facilitate a smoother transition. So you have to meet them on their level. So with discharge planning, at our facility, we have really good educational materials for the family to take home. So we'll have books that kind of explain what's happened to their family. It'll explain a brain injury to them. We make recommendations for durable medical equipment, so if they need a walker when they leave, or if they need a wheelchair, you have to set that evaluation up, right? Sometimes we'll do home assessments if necessary, so just making sure that their home is accessible for them, that they can function within their home safely. Definitely teaching family to keep things that they could harm themselves with out of reach. And then recommendations for continuation of care. So you know that like you have the ability to discern where they go from you. You have the ability to recommend what they go to. So being able to discern that accurately is something that you will get with practice when you're out in clinicals and you see your CIs doing that. Okay. So special populations with TBI. So blast injury. So this is sustained injuries during warfare by soldiers. There's 3 different types. There's primary, secondary, and tertiary. And then I have, I think that's a video of a soldier talking about it. Jazz, let me see your book. Oh, they do, don't they? Look at there. Okay. Can you read that for us? Primary, secondary, and tertiary.
Okay, primary injuries occur from the impact of the blast wave. Structures with an air-solid interface such as the lungs and tympanic membrane are especially susceptible. And then secondary injuries can occur when soldiers are hit by shrapnel, such as rocks and pellets from detonating improvised explosive devices. And then tertiary injuries occur when soldiers are thrown off their feet and propelled into objects, sustaining traumatic injuries and fractures.
So, we've had a few of those. So also remember that this doesn't actually have to happen within warfare. It can happen in training too. So because we're so close to Fort Benning, a lot of times we'll get those injuries, for treatment as well, from training. I had a guy fall out of a tree, during training when he was jumping. So he jumped, landed in the tree, and then when they went to recover him, they cut the branch and he fell. It can happen in training. And he had jumped, I think,
few times before that.
It only takes once.
Can you take me by the hand? Feel better again. Whoa, I feel better now.
When we think about military-related TBI, what often comes to mind is blast injury, which is this idea that you don't need to have a direct blow to the head to sustain a concussion or brain injury. We're only beginning to understand through research how that may be different. What we're starting to look at is the neuropathology. So how does the blast wave affect the brain, cortical structures, subcortical structures differently than maybe a direct contact blow to the head, like you might see in football or boxing, or even something like a motor vehicle accident. This is a really new area of science that's not as well understood as we'd like it to be, but we think it's an important linkage for developing specific treatments for this injury. So what we've learned so far is that a couple of things. Blast injury is different in how it affects neurons and the brain. We've also learned that the rapidity of injury might be an important reason for why people feel as impaired as they do. And so, for example, if you have one hit to the head or suffer one perturbation of brain function, like you would around a single blast, or let's say a single blow to the head, and then you have a long period of time to recover, that may not be so bad. What we're beginning to understand through various animal models and others is that if you have repetitive hits, such as being on the range and setting off 20 or 30 rockets, you likely have a different exposure pattern, different neuroinflammation than, say, a single hit. And that's going to become very important, both from a treatment perspective and then even earlier up the chain from, say, a prevention perspective. So it's one, the mechanism, but then two, how frequent and the interval between hits. That's probably very much going to matter in terms of symptomatology and potentially outcomes. So when somebody enters our TBI program, we try to do a very in-depth interview on their exposure. We actually start all the way from childhood. Many people enter military service, had plenty of concussions before they got there. For example, they played football throughout middle school and high school, or soccer, or maybe MMA or other sort of martial arts. So they have some exposure even pre-military service. Then in military service, you know, we always think about combat-related injury, but there's also training-related injury and other sorts of exposures. We actually do a full brain injury or TBI history, starting from birth, really, all the way until the time that they come to see us, trying to characterize the different exposures and the different types of injury. So even if they all fit into the bucket of concussion or mild traumatic brain injury, they might be very different in how they were acquired. And we try to understand that now as we learn more about these injuries that may change what we do later.
Brainline is powered in part by Wounded Warrior Project to honor and empower post 9/11 injured service members, veterans, and their families.
Okay, so I think she did a really good job of explaining kind of blast injury and how that can impact your patients, and how if a patient has already had injury before and then they present to you again post another injury, that you can see some deferment from the first one, some symptomology that may have still been present before that, and getting a good history on your patient is going to be important, right? Do y'all have any questions? It's really short. Okay, so in your book, your Humphrey book, there is a case study in the back of the chapter. What I want you to do is I want you to read your case study and answer the questions that come along with the case study. What page is that, Jazz? What page does it start on?
308.
308, page 308. There's 3 questions up there. Yeah, there's 3 questions to answer. And then I want you to create your intervention plan that we've been doing for the other ones for your TBI patient. So I don't care how many exercises you do or how many activities you do, but at least do 5.
That's for what's the news? But these are just answering questions, we're not doing that.
Along with
The ranchos, Los Amigos. So you have an hour to start working on it and asking me questions. So I'm gonna let y'all get started on that. I'm also gonna let you just pair with whoever you want. I'm okay with that. Okay?
Is this due the same day as the other one?
Mm-hmm. Next Thursday. Yeah, the 3 questions and your intervention plan for this patient.
So we're doing that and the 8 for the other one?
And you can look in your, checkoffs on, under TBI, it has you making that chart with the interventions on it. So that was my idea.